The agenda for my presentation will be about the Danish guidelines for subacromial impingement syndrome. Are they useful? Scapular dyskinesis as a subclassification of subacromial impingement syndrome. The clinical tests we use, are they reliable and valid? And the relations to kinematics and muscle activity. And then our challenges for finding the right evidence for treatment of this condition. So we all know that subacromial impingement syndrome is the most common shoulder injury. It costs a lot of money, and it's a painful condition of especially the rotator cuff tendons. Several explanations have been suggested as the reason, both internal and external factors, and today I will, as opposite as yesterday, where we talked about rotator cuff tendinopathy, we talked about the internal factors. Today, this morning, we will talk about the external factors, the more functional and structural changes. So in Denmark, both visitation and clinical guidelines were prepared and published for treatment of subacromial impingement syndrome. And in both guidelines, it stated that the definition of impingement syndrome is, as you can see here, designates pain occurred by movement or load of the arm, especially when the arm is lifted towards horizontal and above, and where the pain is triggered by either impingement, changes in the bursa, and or changes in the tendon itself. And the guidelines focuses on the impingement part mostly. So the visitation guideline for treatment, for non-operative treatment, both in and outside the hospital, suggests or recommends for treatment of subacromial impingement syndrome, patient information and education, training with focus on tissue, stretching and posture correction, muscle control of scapular stabilizing muscles, and stabilizing and strengthening exercises for the glenohumeral muscles as well, with a duration of 3 to 6 months, but there's nothing about which exercises or the progression. And actually, it's stated that they should be updated every 3rd year if there's nothing against this. The clinical guidelines also recommends, these guidelines came a little bit later, use of training, possibly including manual therapy and tissue stretching, also with a duration of 3 months. However, again, our problem is, as you can see here, the 5 primary studies, which were the basis for the recommendations, were very different kinds of exercises-specific training with glucocorticoid, steroid, scapular stabilizing exercises, dynamic humerus-centric exercises, maybe supervised or non-supervised training, but there's nothing about the effect of treatment length. So it's really unclear with specific training for subacromial impingement syndrome. And this is why it's so difficult to use these shoulder guidelines on subacromial impingement syndrome, because there's no recommendation for specific subclassification, and there's still too few specific training effect studies on this area. So as suggested also in the clinical guidelines, this is a multifactorial condition with different tissue problems and can be, as recommended in Ancoul's clinical reasoning algorithm, according to the location and the cause of the pain condition. We will look more into the scapular dyskinesis condition and look what it is and what the characteristics are. First, we will define what is scapular dyskinesis as how it is defined in the literature. Clinical term for visual scapular changes from the normal kinematics, also sometimes with some thoracic posture abnormalities. When looking for kinematic changes or abnormalities, we can use static or semi-static tests for characterizing whether a patient has scapular dyskinesis or not. We can also use some more dynamic tests for identifying scapular dyskinesis, as suggested here, 5 repetitions in both flexion and abduction, a kind of fatiguing test, and we can rate it as normal, subtle abnormality, or obvious abnormality. And these are the references where the reliability has been looked at. But in general, we have some problems, since a recent review showed that many of these clinical tests who are used to identify kinematic changes in relation to, for example, scapular dyskinesis, have some problems with the clinic metric. Not so much the reliability, but especially the validity and the responsiveness of these clinical tests can be problematic. And the recommendation of this recent review are that future studies should test and improve the clinimetric properties, and especially the diagnostic accuracy and responsiveness to increase the utility for clinical practice. What about if we use more advanced methods for identifying kinematic changes, as for example, three-dimensional video, electromagnetic sensors, or inclinometers, to try to identify whether there's a scapular dyskinesis in subacromial impingement syndrome? And as you can see, this review from 2014 went through a lot of literature, and both looking at upward rotation, anterior tilt, medial rotation, and scapular elevation for this group of subacromial impingement syndrome. And again, we unfortunately they not found a clear pattern for scapular dyskinesis, but however, there were some tendencies showing that in CIS there was a decreased upward rotation, and it was a predictor for pain. The explanations for this somewhat unclear pattern were that there were many different definitions of CIS, since it's a multifactorial nature. There were different methods for measuring these scapular positionings, limited reliability and validity also with the advanced measurements, not only for the clinical tests. And the question which they raise in the discussion section is there a normal or abnormal scapular positioning? And do we know what the normal variation is? However, they showed there were two typical patterns. You can either have a decreased upward rotation, or you can have an increased upward rotation. The decreased upward rotation may be a cause for development in the future of CIS. An increased upward rotation may be a compensation mechanism for avoiding CIS. When looking at one other definition of scapular dyskinesis, in addition to the kinematic changes, it's also said that it's a visual imbalance. Can you see a visual imbalance in muscle activation? Muscle strength maybe also. So what does the literature say about this abnormality or muscle imbalance? Well, two systematic reviews went through the literature and looked in this population of CIS, how is the muscle activity and how is the muscle recruitment? Again, there was no clear muscle activity pattern, but showed some tendencies to an increased activity of the upper trapezius muscles and a decreased activity of the lower trapezius muscle and the serratus anterior muscles. The explanations, still as in the other review, small samples and varying diagnostic criteria, and very few of the studies had subclassified the CIS into, for example, scapular dyskinesis. And also they used very different testing procedures, and very different EMG variables were reported. So actually the recommendation of this review is to try to subclassify subacromial impingement into, for example, scapular dyskinesis, to be more clear of what the evidence could be in this condition. So the challenges are here. If we do not subclassify, we have, as you can see, many black boxes. We have a mixed population. We do a general clinical examination. We prescribe a mixed training. And we don't know really what the effect is due to, if we got an effect. We can also be more specific in subclassifying impingement, for example, into scapular dyskinesis, verifying this condition by the assisting movement tests. We can also use the fatiguing tests, the more dynamic tests, and look at the scapular positioning. We may also use ultrasound actually to look whether the impingement, whether the tendon of the supraspinatus goes smoothly under the acromion, or we can look at the acromial humeral distance to see whether it's tight or not, and to be more sure whether we have a scapular dyskinesis condition or not. And we can prescribe our motor control training, which is still one of the black boxes in here, and we can test the effect of the scapular dyskinesis. Was it actually targeted, and was it reduced after our intervention? But as mentioned and indicated, we still have some challenges in which motor control training to prescribe. There seems to be some evidence for motor control training, probably also due to some of the patients having scapular dyskinesis, since it also seems to be targeted mostly in this condition. But do we know for sure that it is a problem always? And the big problem is also that scapular dyskinesis is not measured afterwards or actually reported whether it was reduced or not. I will go through a few studies trying to look at the motor control training and whether the right problem was targeted and reported afterwards. So this is a study, an uncontrolled study, unfortunately, targeting motor control retraining. They included cis, a mixed population, as you can see, and they actually got some results both on kinematics and EMG activity, and also self-reported outcome. It targeted motor control. It was actually, some of the problem was actually scapular dyskinesis, or you can say they got a successful effect on scapular dyskinesis. Still an uncontrolled study targeting scapular muscle rehabilitation. Here they actually both included people with subacromial impingement and scapular dyskinesis. So they were more precise in their inclusion criteria. Again, scapular dyskinesis was part of the problem here. There was some effect, successful effect, both on patient-reported outcomes and muscle balance actually, because they succeeded in decreasing upper trapezius muscle activity and decreasing the ratio of the upper to the lower or serratus anterior ratio, and they increased the onset of lower trapezius and serratus anterior versus the upper trapezius muscle. And the third study, which is Struyf, and he will probably comment on it. Here again, scapular-focused treatment. They have cis, a mixed population, a targeted scapular motor control training versus stretching, massage, and mobilization. So we don't really know from that study, maybe he can comment on it afterwards, was scapular dyskinesis the problem? There was a successful effect on patient-reported outcomes and pain-provoking tests, but was scapular dyskinesis measured and reduced? We're not sure about that. And the last study by Holmgren, again, a mixed population, where one group got specific exercises targeting motor rotator cuff and scapular stabilizers versus a more unspecific movement therapy program. And here, there was a successful effect on patient-reported outcome, and especially a reduced need for surgery. But again, we don't know whether scapular dyskinesis was measured or reduced. So I will finish my presentation here by giving some indications of future possibilities for treatment maybe of this group. Maybe could it be so that in the future we could use some more technical aids for motor control learning or retraining? As a recent promising results of the study showed that both subacromial impingement patients and healthy subjects were equally good in selectively activating the scapular muscles with biofeedback, EMG biofeedback. But however, the cis group was poorer without biofeedback. So maybe there's a potential for learning in the cis group as well as in the healthy control group. And one of the presenters here in this session, Camilla Larsen, will actually talk more about this EMG biofeedback as a technical aid for improving motor control relearning. So thank you very much for your attention.
Thank you very much, Birgit, and thanks again. It's my third presentation at this stage, but again, just thanks to the committee for giving me the opportunity to be here and speak with you and to enjoy a fantastic couple of days on my first trip to Denmark. I'm Dr. McCresh, and I'm a university lecturer and researcher in the west of Ireland, and today I'm going to present some work from my PhD, which I completed about 2 years ago, looking at different parameters of the subacromial space. So I'm not going to talk so much about the scapula as some of the other presenters today, but I hope I'll be able to put in context how my work might fit with thinking about the scapula also. I can't resist doing a little bit of work for the Irish Tourist Board while I'm here. So this is where Limerick is, that red dot over there on the west coast of Ireland. Very beautiful city, and we're bidding for City of Culture 2020, European City of Culture 2020. So you hopefully will hear lots more about us if we win that bid. And this is my university, University of Limerick. Again, I would contend one of the most beautiful university campuses in Europe, because the River Shannon cuts the campus in half. So that's my building there, and it sits where the red dot is, right on the riverside. So I'm quite lucky to work in a very beautiful place and with some great people. We're a young university, but a great place to visit, and as I said, a very healthy environment in which to do your work. So today, broadly we're going to talk about shoulder pain, and you've heard these discussions quite a bit over the last couple of days about how shoulder pain is highly prevalent in the adult population. I have got hold of some data from the Irish population, a big study of chronic pain, 1,200 Irish people, and I've looked at that study a little bit in terms of shoulder pain prevalence, and prevalence is 13% in that particular group. So across Europe, that sort of 10 to 20% prevalence seems to be pretty consistent. Patients don't get better quickly, so up to 4 out of 10 patients with shoulder pain still complaining of pain 12 months after the onset of their first episode. And also, they tend to have very poor quality of life and quite high rates of psychosocial or psychological comorbidities. If we go back a little while, so when we think about the subacromial space, it's important to think about Charles Neer. So in 1972, he proposed the acromial irritation impingement theory. He proposed it in sort of a review paper. I think these days we'd probably call it a blog. But it had an enormous impact in terms of, he then went on to propose the acromioplasty procedure as the solution for this acromial irritation that was causing the damage to the rotator cuff tendons. And as we know, and some research presented by Andy Carr suggests that the rates of that subacromial decompression or acromioplasty procedure have absolutely gone through the roof. We've got studies that suggest there's a 700% increase in that procedure in the last 10 years in America. So really it's a procedure that's rapidly increasing in the numbers of procedures being done, mainly probably because we've got a much older population. But we have to question whether that huge increase in doing that procedure is related in any way to the efficacy of the procedure. So normally you'd think, well, if you're going to do 700% more of something, then hopefully it's based on that procedure being a lot more effective, or certainly the treatment of choice. And if we don't have that evidence, then perhaps we need to question to some degree. So there definitely are challenges out there in the research to the impingement theory or the acromial irritation theory. We've had studies here from Scandinavia that suggest that, you know, if you just take out the bursa and don't do anything with the bones, then you can have equivalent outcomes in surgical procedures. That what we see in terms of type 3 acromions may in fact be a secondary phenomenon, and that what you actually see in the acromion is an osteophyte, in the same way as we might see with the plantar fascia. You develop an acromial spur in plantar fascia disorders very often. Well, this is suggesting that maybe what we see in terms of a type 3 acromion is in fact, you know, a spur on the coracoacromial ligament. We know that when we look at where the tears occur in the rotator cuff, they're predominantly on the joint side, the inferior side of the tendons. And if this acromial irritation theory were to hold water, you would think that most of the damage to the tendon would be on the superior surface. So there's evidence to suggest that, you know, we need a more sophisticated model to try and explain why this particular type of shoulder pain might be occurring. So let's have a little talk about the subacromial space. This is where it is. There, okay. It contains the subacromial bursa and the rotator cuff tendons. It's bordered by the acromion, and the coracoacromial ligament on the top forms the roof of the space, and then the floor of the space, the rotator cuff tendons, the glenohumeral joint capsule, and the humeral head. It measures in and around 1 centimeter on average, so it's not a big space. And we know that over the years, you know, research has reported that a loss of space is observed in rotator cuff pathology. So why might there be a loss of subacromial space in rotator cuff pathology? Well, these would be the theories, that there's superior migration of the humeral head, which might be related to rotator cuff muscle dysfunction. That thickening of the coracoacromial ligament might encroach on the space. That bony thickening or encroachment from osteophytes, encroachment from osteophytes on the acromion or coracoacromial ligament also may reduce the space. Fitting in with today's session, that altered kinematics or altered position of the scapula, of course, because that will alter the position of the acromion and the coracoid. That might also lead to a reduction in subacromial space. Or if the bursa or tendon are thickened, that might also change the relationships or amount of space that's available. I presented this yesterday as part of the paper I was presenting, but you know, when we think about rotator cuff tendinopathy, we try and understand why it occurs. People tend to split themselves into this idea of intrinsic or extrinsic mechanisms. Intrinsic mechanisms being things that are driven from within the tendon, like the person's age, their family history, lifestyle factors, blood flow to the tendon, but also, I suppose, the king being load. And we know that rotator cuff disorders are heavily associated with either excessive load or perhaps unaccustomed load on a background of low load or a background of unloading. Extrinsic mechanisms, things that are essentially external, and we're thinking more about biomechanical forces here, I guess. Things like acromial shape, scapular kinematics, and muscle dysfunction also being a key consideration when we think about external factors that might be influencing the rotator cuff tendons. And this work is nicely summed up in a paper by Amy Seitz back in 2011 in Clinical Biomechanics. What I was interested in was thinking about that surely it's not quite as simple as any one of those, but that potentially there's some interaction between these different mechanisms. And when I visualized what I wanted to understand in my PhD was this idea that, you know, I'm a physiotherapist, I've seen plenty of fat, thick Achilles tendons in my time, and I can see them, but I can't see the rotator cuff when my patient comes in with shoulder pain. But if I imagine that it might look like this, it might be thickened, it might be swollen, what does it mean then to say, well, that thickened tendon is sitting in the subacromial space, and what effect might that have in terms of the relationships in there or the mechanisms of what near-classically called impingement might be? So, you know, we know that changes in tendon size or volume are a factor in tendon pathology. What I wanted to ask was, well, what's the impact of that swollen tendon in the subacromial space? When you do this as part of a PhD, you take a systematic approach to it, a structured approach, because you know you're going to be sitting in front of somebody in a viva. You need to make sure you've got all your bases covered. So I'm going to go through a little bit of the methodology that I used initially, which inevitably, I said in PhD, perhaps captures more of the time than you'd like to. So when I had a look at this area, of course, the key thing was how are we going to measure the subacromial space, because that was going to be key to doing a reliable or valid investigation. So first thing I did was a systematic review, examining the radiological methods that were available to measure the subacromial space. And we used the acromiohumeral distance as a proxy for measuring the subacromial space. And already we have a limitation, because we're using a 2D method to measure a 3D phenomenon, okay? But that's a limitation we have to accept often when we're doing this in a clinically applicable way. So the acromiohumeral distance is the proxy for the subacromial space. So I had a look at MRI, CT, and X-ray, along with ultrasound, and all of the studies that have looked at measuring the subacromial space using those different radiological modalities. It was a systematic review. We had looked at 18 studies, 8 of them were high quality. The best reliability evidence was there for ultrasound compared to the other radiological options. They were quite poorly studied in terms of the reliability, in fact. But even within ultrasound, there was very limited data on inter-rater reliability, and only 2 studies that had examined symptomatic populations. And there was no information at all about the validity of this measurement method. So as a PhD student, you cringe and think, oh no, that means I'm going to have to do the validity study now as well. And so that was step number 2, okay, which has been a very interesting part that almost took me away from my main question, but that's something that happens. We tried initially to look at validating this method intraoperatively, which was my immediate reaction as to where we should be going. But to cut a long story nice and short, it just didn't work trying to do it in theatre. There were too many other variables in terms of the arm position, the fact that they have to fill the shoulder up with fluid. The surgeons among you will know that, again, there's lots of things about that, the intraoperative environment for the shoulder that wouldn't carry over to then doing it in the clinic. So our intraoperative methods didn't work. So we went completely the opposite way. At the time, I was training in sonography, and I met some people who designed radiological phantoms. And I said, this sounds like it might be one of the answers to looking at this question. So I worked with a very fantastic group at the University of Leeds who are involved in designing ultrasound phantoms. So a phantom is essentially a lifelike or a anthropometrically, as close as we can to anthropometrically replication of a joint, which is then embedded in some kind of soft tissue, so again, a substitute soft tissue, that are used to validate and calibrate different radiological methods or different radiological machinery. No one had ever made one of the shoulder before. So again, problem number 2 for the PhD student. Nobody had done it before. So again, this method was highly informed by the work this group had already been doing. What we ended up doing was taking a CT scan of somebody who had shoulder pathology. We used their CT scan to create a model, a picture of their shoulder here using CT, and we used a 3D printer to print out the bones. So we used a CT data to then print out a set of shoulder bones of somebody who had rotator cuff pathology, and so this is what our printed bones look like. And again, there's a long bit of work to be done deciding obviously on what materials you're going to use and so on, that if somebody wants to know about, they're welcome to ask. This is where it ends up, because you then embed it in gelatin, and we covered it in latex to make it look as much like a human shoulder as we can. And then when I say that, people go, that's supposed to look like a human shoulder? So that's a human shoulder lying on the plinth, okay? We christened it the ugliest birthday cake you've ever had. More so even because it has to be kept in the fridge, because it's made of gelatin. So, phantom made, so the process was making the phantom, setting the bones together, measuring the bones before we embedded them in the soft tissue. So we measured the bones, we also measured on the CT, so we had the CT measurements, we measured the physical bones, then we embedded them in soft tissue, and then we took an ultrasound scan of the phantom and attempted to see if we could, again, get the same measurements in the phantom as we did on the printed bones and on the CT scan. What's important when you're making a phantom is fidelity to the normal radiological appearance. So on the left here, we have a picture of a normal human shoulder and the subacromial space. So we have the humeral head here, we have the acromion, and this is the acromiohumeral distance that we measure. And this is as close as we could get in the phantom to that. So we didn't have any tendons in the phantom, of course. So we just had the bones and we had the soft tissue. So by standards of a radiological phantom, this is quite good, but as you can see, there are some differences. But essentially, in terms of what we were trying to measure, it was a good replication. And again, long story short, we did a Bland-Altman analysis comparing two methods of measurement. Between the measures with the calipers on the real bones and then in our ultrasound phantom, and the mean difference was very small. The limits of agreement were very tight, so we're very happy that in the method that we used, the construct validity of acromiohumeral distance was good. But again, it's construct validity, and there are other types of validity that you might want to look at as well that this method may not entirely be able to represent. So when you've done validity, then reliability becomes important. And as I said from the systematic review, there were definitely gaps in the reliability information. So again, not to dwell too much on this aspect, but I did an intra and interrelated reliability study. I did it in a symptomatic population. The testers were me, a physiotherapist who's trained as a sonographer, and a very experienced consultant rheumatologist. We got excellent reliability for both the thickness of the supraspinatus tendon and the acromiohumeral distance. Both intra and intra-rater reliability were above 0.9 for the ICCs. The minimal detectable change values were also generated by this study, so then I was able to carry those through into the next part of the investigation to understand my possibilities for measurement error. Okay, so then the next important thing was to try and understand these measurements in people with rotator cuff tendon pathology. So the acromiohumeral distance and supraspinatus thickness we then examined in a group of people with rotator cuff tendinopathy and age-matched controls. And this was a cross-sectional study, purely just trying to look at these parameters in this population. So the controls were mean age of 50, mix of half and half males and females, and again, the rotator cuff group, again in the 50s, 54, half males, half females, and no differences between the groups at baseline. Something that we've calculated, and Laurie Mitchener has also done some work on using this a calculation in her work in America, is we looked at the subacromial occupation ratio to try and get a relationship between the subacromial space and its contents. So we calculate that by dividing the supraspinatus thickness by the acromiohumeral distance. And essentially it's just a ratio of the space to the contents. So it's an easy way to look at both aspects of the condition. So there was no difference in acromiohumeral distance across the two groups here, which didn't exactly match with some other studies. Now, what I would say one key difference for us is we excluded people with full thickness tears because we were unable to measure the thickness of their tendon. So in populations with full thickness tears, and if you do divide up in the literature and look at people with tendinopathy or people with tears, there's definitely a higher rate of change. The subacromial space reduces more when there's a full thickness tear than in people with partial tears or tendinopathy. So there was no difference in subacromial space across the controls or the symptomatic group. The supraspinatus tendon was thicker in the whole rotator cuff tendinopathy group. But then we divided them up. My statistician helped me out in terms of dividing the 40 of them up into, so the controls are on the left here. This is the no pain group. These are the 40 people with pain. We divided them into mild, moderate, or severe pain across that 0 to 10 scale on the numerical rating scale. And the supraspinatus tendon in particular was larger in those with higher pain levels. And therefore, unsurprisingly, the occupation ratio was higher in that group. So although their subacromial space was no smaller, their tendon was thicker, so we looked at the ratio between the two, they had a higher subacromial occupation ratio in the group who had higher degrees of pain. So the group with mild pain were exactly the same as the controls in terms of their subacromial space parameters. So no difference in space, thicker supraspinatus in the pain group. And this was the beginning of suggesting, well, maybe if the subacromial space isn't changing in this group, but the tendon is because it's clearly thickening, are the primary tendon changes more prevalent than the actual reduction in subacromial space in people who are, not at the very degenerative end of the scale. So when you do the cross-sectional study, that's all very well. And again, as a physiosonographer, I always get very aware of the fact that we image people generally when they've sat in a waiting room for maybe an hour, they haven't done any movement, and of course, because you're coming for a scan on that particular day, it'll be the day that you have no pain. So I was interested in the idea of maybe imaging as a modality, but actually looking at people when they'd done some loading. And also then attempting to match some of the work that had been done in the lower limb, particularly by people like Nicole Grigg in Brisbane, trying to understand what happens to the tendon when we do an acute loading protocol. This had never been done in the supraspinatus tendon before, so we wanted to have a look at the acute effect of loading on the morphological properties of the supraspinatus tendon, but also, of course, in relation to the subacromial space. So the aim was to look at the 24-hour response of the supraspinatus tendon to a bout of fatiguing exercise. We took 20 controls, 20 people with rotator cuff tendinopathy. We used a Biodex machine to give us a very clean, reproducible, fatiguing protocol. We used a combination of abduction and external rotation movements. We used both concentric and eccentric movements. This work the protocol was based a little bit on one that had been designed by Jean-Sébastien Roy in Quebec for a previous study, so we adapted that protocol. The aim was to get 35% fatigue in both abduction and external rotation directions. So both groups did the protocol, a couple of minutes, and then both groups got scanned at 1 hour, 6 hours, and 24 hours after they did the exercise. Okay, so we're going to have a look at supraspinatus thickness before, at 1, 6, and 24 hours after the exercise. So we have the controls on the left, no change. Okay, so for the controls, the thickness of the supraspinatus tendon did not change across the time scale. There was a tiny little dip, but nothing that we could suggest was a true change. In the rotator cuff tendinopathy group, so again, we've got time 1 baseline, 1 hour, 6 hours, and 24 hours after they did the fatiguing exercise. Whoops, excuse me. And we can see that there's an increase in supraspinatus tendon size, which occurs, between the 1 and 6 hours and takes up until the 24-hour period to return to baseline. And it did return to baseline by 24 hours on average, but not by 6 hours. So at 1 and 6 hours, we had an increase in supraspinatus tendon size that was greater than the minimal detectable change for that measure. Controls no significant changes at any time point. And so what was also, of course, of interest then is, okay, if we've got tendon that's thickening or swelling, what's happening to the subacromial space? And it wasn't news to us at all that both groups showed a reduced subacromial space, because there's lots of studies that show if you fatigue the cuff, the humeral head rides up. Biomechanical studies, occupational studies, so that wasn't new. We expected to see a change in subacromial space. We saw it in both groups. However, in the controls, it had returned to baseline somewhere between the 1 and 6 hours. So in the controls, it dropped a bit in an hour, but 6 hours, their subacromial space had returned to baseline. However, in the rotator cuff tendinopathy group, it was until 24 hours before their subacromial space had returned to baseline. So what am I trying to say? Well, if we try and understand that, why would we be getting a swelling response in the supraspinatus tendon? Well, Nicole Grigg's work in the Achilles and lots of lab-based studies and so on will tell us that exercise squeezes fluid out of the tendon, and thickness should reduce when you do exercise. We didn't see a reduction in tendon thickness in our controls, interestingly, so we just saw static. But certainly in our pain group, we saw an increase in tendon thickness, suggesting that there's an abnormal fluid mechanism or metabolism in rotator cuff tendinopathy. And people, I think it was Craig perhaps who mentioned it yesterday, that the idea of the tendon having large proteoglycans that hold on to water and therefore don't let it go quite as easily as they would do, or as we might expect them to do during an exercise protocol or an exercise event. So the question here is, does the enlarged tendon, when you combine it with a superiorly migrating humeral head, increase the potential for impingement signs and symptoms as a secondary phenomenon, but that the primary phenomenon is what's happening in the tendon, and what we're seeing in terms of maybe increased potential for compression might be a more secondary phenomenon. But also, as was emphasizing, that clearly there's a real interaction between what we might consider to be intrinsic mechanisms and extrinsic mechanisms that are at play when we see rotator cuff tendinopathy. And just, a brief, I suppose, interpretation for clinical practice. And some of this is definitely a leap. I would say that it's conjecture from my point of view based on the study, and there's a real need to examine this further. What we might suggest that maybe loading to fatigue in irritable presentations isn't a good idea. If their tendon's going to be swelling up, loading them to fatigue repeatedly is not going to be helpful. You're going to increase their risk of compression in the subacromial space. Maybe we look at strength and conditioning principles a little bit more, and we load once a day or even only every second day, so that we give the tendon time to recover. You maybe want to limit exercises to only 1 or 2 rather than lots and lots of exercises, so that you don't overly fatigue the rotator cuff. And again, that fits with things that Chris Littlewood said to us on the very first morning here. So it's nice sometimes when those things tie up. But there's a real need for studies, as Birgit has picked out, to examining exercise dosage and examining the frequency of exercise that we're going to deliver for this condition. So certainly lots of PhDs available. And I would say, just as a sum up, really, is don't always blame the space, think of the contents too. So think of the relationships in there and how your rehabilitation might be affecting the relationships between the contents of the space, and not just seeing it in terms of a biomechanical thing. I'd like to thank my PhD supervisors, that's Dr. Jeremy Lewis and Professor Alan Donnelly at the University of Limerick, and I had some really helpful people who co-authored with me, and I was supported partially by the Health Research Board of Ireland to do my work. Thank you.
Thank you very much.
Okay, thank you, Birgit, for inviting me in this very good congress. It's a very nice schedule here, and I'm from the University of Antwerp, and like Karen, she's promoting Ireland. I have to promote Belgium. I have to promote Antwerp. That's a part of it. This is Belgium. You all know that this is Belgium, of course. And I would like to locate our city, Antwerp. This is Antwerp. And the people in Belgium, they often say that we people from Antwerp, that we like to present ourselves as feeling better than other people in Belgium. But of course, it's completely wrong.
Is it possible for you to hear back what is said? Okay, thank you.
Okay, so I'm just giving a close-up of Belgium. You can see, of course, Antwerp and our great parking spots. Antwerp, we also have a very nice university and a very nice city. You see here our city, Antwerp. It's one of the most beautiful cities of Europe, after Kolding probably, but it's one of the most beautiful cities of Europe, famous for our diamonds and famous for our symbol here, which is, and if you take a closer look, it's an overhead athlete. Our symbol of Antwerp is an overhead athlete, so it's in our genes to do shoulder study. This is our university. A beautiful old building. I haven't been there a lot because we are in an ugly building, but I present this one. It's also part of our university. It's a beautiful place. But I'm not here invited for speaking about Antwerp, but I'm invited to talk about the relevance of scapular dyskinesis. And it's quite a difficult topic. There is a lot of discussion on the relevance of scapular dyskinesis and whether it predicts pain or not. And when I was preparing this PowerPoint, first when Birgit asked me just present your study on we did a prospective study on whether scapular dyskinesis predicts shoulder pain or not. But we encountered so much other studies that had other conclusions. And for today, for this presentation, I summarized all the studies together to get a somewhat clear view on whether it predicts shoulder pain or not. So I'm not going to talk only about my studies here. You see 2 cases. I'm going to present today on scapular dyskinesis by presenting you 2 cases, one with shoulder pain and one without shoulder pain, and just try to transfer it to practice what we're going to do in either those cases. And another thing I would like to do is present to you the way I would like to look at a shoulder when I look at a shoulder when I want to rehabilitate a shoulder, what's a nice way to look at a shoulder? And I often use the metaphor of a soccer team. I'd like to compare a shoulder with a soccer team. And for this presentation, I chose the soccer team that's at the moment at first ranked at the FIFA World Ranking. And it's a totally coincidence, the Belgian team who's first ranked at the FIFA World Ranking. And I'm going to compare how to look at a shoulder as a coach looks at his soccer team. But I'm going to come back to this one at the end of my presentation. Okay, 2 cases. I told you about 2 cases. If it works well, I have 2 small videos. Let's look at the first one. First elevation, and you see the next one. And you can see a clear, obvious scapular dyskinesis on the right shoulder. How can I say it's an obvious scapular dyskinesis when I don't know what is normal scapular movement? But still, everybody sees that this one has an obvious scapular dyskinesis without us knowing what's normal. I think it's possible to say, well, this scapular performs an abnormal, if I can use that word, an abnormal movement without knowing what is really normal. And in fact, that's the whole question here. Normal is such a variety. We cannot define exact what is normal, but we can define what is clearly abnormal. And that's this case. This case is, for instance, left patient is a shoulder pain patient. Let's look at the right. Case B. Goes very well. Okay. So those 2 cases have an obvious scapular dyskinesis at their right shoulders. But the first one is a shoulder pain patient. She is having rotator cuff symptoms for over 6 weeks and has scapular dyskinesis. While the second one is pain-free. She hasn't had shoulder pain ever. And now the question is, what should we do in this case and what should we do in that case? Okay, I would like to start with answering the questions around the first case and discussing what's the relevance of scapular dyskinesis in a shoulder pain patient? And we can only answer that question by looking at randomized clinical trials that try to do an intervention focused on the scapula and look if this intervention has a better outcome than a control intervention. And as Birgit said, it's not that easy to find good randomized control trials. A lot of studies have an uncontrolled design, but I'm not a great fan of presenting uncontrolled studies here. We did a systematic review with a small group. We did a systematic review on the effectiveness of scapular-focused approach in patients with several shoulder pain problems. As you can see, there were 6 randomized controlled trials included, all with a control group. 6 included, 4 on rotator cuff tendinopathy, 1 general undefined shoulder pain, and 1 on frozen shoulder. Of course, the one on frozen shoulder is difficult to compare with the other studies. They all had good quality score. Okay, I'm not going into the methodology of the systematic review, which is, by the way, hopefully going to be published in British Journal of Sports Medicine one of these weeks. And our results are very conflicting. For the first one is quite logic. If we train scapulothoracic muscles, then we create more strength in scapulothoracic muscles. That's not something that is very surprising. But the other one is very important. How about pain and function in our shoulder pain patients? And actually, we have conflicting evidence that a scapular approach has a benefit above control interventions. Control interventions that I will discuss later which were very variable. So the conflicting evidence, what does that mean? That means we have studies that saying scapular-focused treatment is better than rotator cuff training, and others say scapular dyskinesis training is not better than rotator cuff training. So then we have conflicting evidence. How come we have conflicting evidence here? First thing, of course, we had 6 different RCTs. We had 6 different control groups. You can see here we have mobilization, scapular glenohumeral mobilizations combined with strength exercises. Some did passive range of motion exercises with active range of motion exercises. Some had a control therapy that was only consisting of taping, scapular taping. Routine physiotherapy treatment. That's also something that's often used in methodology. The control therapy was routine physiotherapy treatment. What is routine physiotherapy treatment? I don't know. Manual mobilizations, and even one had a placebo group with no intervention, no real intervention. So it's very difficult to say, oh, well, we have moderate evidence or we have a strong evidence towards scapular-focused approach. We cannot do that. We had conflicting evidence. If we do not know whether the scapula, and that's, I think, an important thing, if we don't know whether the scapula is the contributing factor to the patient's shoulder pain, then we cannot presume that the patient will benefit from it. And that's, I think, an important thing, and I was glad that Birgit presented it early this morning, that there is some type of classification maybe necessary here. For instance, if we look at two different studies, one is included in the systematic review, one is not. This one is of Christophe de May, which Birgit also presented, which was not included because it's an uncontrolled RCT, and our own RCT is a controlled one. And what's the issue here in these two studies? They both demonstrated excellent outcome in favor of scapular approached program with or without control group. The first one without, our group had a rotator cuff training. But the difference of these two studies with all the other RCTs is that we classified our patients as having scapular dyskinesis together with rotator cuff symptoms. And not only scapular dyskinesis, but also scapular dyskinesis which was related to the patient's symptoms. We used this scapular assistant scapular retraction test in order to know whether our patient will have a benefit from a scapular approach. And when we do that, when we classify or subclassify our patient in having scapular dyskinesis that's related to the patient's shoulder pain, then we will have very much more likely to have a good outcome in our scapular approach rehabilitation program. However, the thing I'm now presenting is this type of studies you can present the way you want. I can present it in favor of scapular positioning, in favor of scapular approach. But I can present these papers in favor of rotator cuff training too, if I want. And that's the whole discussion here. We can differentiate, and we can use our clinical tests. You know, the scapular assistance, scapular retraction test, or a modified, these clinical tests. And if we use these tests, the scope of these tests is your patient has shoulder pain when he moves his arm up. We're going to assist the scapula during this elevation. And if the patient has reduced pain, then this test is positive. Your patient's shoulder pain is related to scapular dyskinesis. That's the way all these tests are published for the moment. And you can go even further and say that the scapular positioning or scapular dyskinesis is the cause of the shoulder pain. Some articles go that far to publish that. But is that the case? Is that happening? If you perform a scapular assistance test and you push the scapula in upward rotation and the patient has lesser pain, does that mean that the scapular dyskinesis was really related to the patient's shoulder pain? Actually, it doesn't really mean that. You can create an enormous lower load to the cuff if you perform that. If you assist the scapula in upward rotation, the cuff has a reduced load for performing an abduction or an elevation. So if a patient has a clear rotator cuff tendinopathy without any relation to scapular dyskinesis, he will still have reduced pain when performing a scapular assistant test. He will still have a positive scapular assistant test, even if the scapular dyskinesis is not related to your patient's shoulder pain. So there's quite a big problem here with these tests, and you can interpret them in the way you want. However, I'm still a fan, and I'm still a fan of these tests for one particular reason, because you can see whether your patient will benefit from a scapular approach together with a rotator cuff approach. And that's the only thing, I think that's the main scope is, will your patient benefit from a training that also includes scapulothoracic rehabilitation? If these tests are positive, okay, probably my patient will benefit from creating a stable base around the shoulder. He will benefit from it. whether or not scapular dyskinesis was really the cause or the consequence of the problem. He will benefit from it. And I think that's more important than discussing whether it was really the cause or the consequence of the problem. So what does these tests do, actually? These modification tests, what do? Do they increase subacromial space? Maybe that's one of the intents of these tests was primarily described as increasing subacromial space. Yeah, maybe they do, maybe they don't. Maybe if they do, it's not that relevant, who knows? Do they create a stable base for the cuff? Maybe that's the reason why they become positive. We can look at that way to scapulothoracic exercises too. Do scapulothoracic exercises increase subacromial space? Maybe that's the reason why they work. Maybe they just create a stable base for the cuff. Or maybe they're just excellent rotator cuff exercises. What is the best way to do a scapular stabilization exercise is to make the scapula move. If you want to make the scapula move, then your scapular stabilization muscles, the trapezius and the serratus, will have to control the scapula. And the only way to make your scapula move is by loading the cuff. If you load the cuff, your scapula is pulled in towards internal rotation and your trapezius will have to work. It's not a coincidence that a good scapular stabilization exercise is this one, just moving your arm up. It's a very good scapular stabilization exercise. Yeah, it's a very good rotator cuff also. Very good rotator cuff exercise also. So these two are supposed to, I think you should look at those two as one whole. And there was this, I don't know who it was on Twitter a few weeks ago. It was Joe Gibson. He said it's like gin and tonic. The scapula and the cuff, it's like gin and tonic. Don't separate them. Okay, so that's for the effect of these treatments. And there's still one issue I should mention, and that's maybe this whole scapular dyskinesis is just an effect of pain. The patient has shoulder pain, and due to the shoulder pain, if it's hard enough, the shoulder pain, it will reach your cortex, it will reach your primary somatosensory cortex, and when it reaches there, it has a potential to inhibit the motor cortex. And it has the potential to inhibit the motor cortex on the left side and on the right side, whether you have pain on the right side or on the left side. So you can have a switch on both sides. And this inhibition of your motor cortex may create a dyskinesis of the scapula just because your patient has pain, not as a cause of the pain. And you can see there are a lot of studies done on that. The first one are all without the shoulder, and I think from Thomas Bandholm here, the Prof. Fallensterer, there are on the shoulder studies also. It's quite important that you see both ipsilateral and contralateral, because that highlights the question, should I use the other side as my golden standard when I look at the shoulder? Because if a patient had shoulder pain, then the other side will have potentially a motor inhibition too. Okay, that's for case A. Do I have to address my patient with a scapulothoracic focused when he has shoulder pain? Maybe if he will benefit if you have a patient with scapular dyskinesis that benefits from the scapular modification test, whether or not this is the cause of the problems. Case B, the healthy one. She has no problems at all. Never had, but has scapular dyskinesis. Should we do anything about that or not? As a clinician, we are very anxious to go working with that sort of patient. We want to get the scapulas sorted out. We want it all symmetrical. But do we have any evidence that that's the right option to choose? What do we need? What do we need to say whether it's predictive or not? We need good longitudinal designs. We need good prospective studies. And we know, the researchers here and the clinicians know that it's very difficult to perform a good longitudinal, good prospective design. And on shoulder pain, there are just a few studies that has a good prospective design. And I will not go into the details of all the studies, but just present you the results of the prospective studies looking at at scapular dyskinesis as a risk factor for shoulder pain. First one by Kawasaki. He tested 120 rugby football players, and his conclusion was the players with asymptomatic scapular dyskinesis at pre-season had a high incidence with shoulder discomfort during their regular season, with odds ratios up to 3.6, which is quite high. So he's actually saying our players without shoulder pain, without shoulder injury, if they have scapular dyskinesis, it will predict shoulder pain. It will predict shoulder pain in the season, 3 months, 6 months later, with 3.6 confidence interval, 3.6 odds ratio. Next one of Myers, scapular dysfunction in high school baseball players. He tested 246 baseball players, and he concluded that this study, scapular dysfunction identified during preseason screenings, is not associated with subsequent throwing-related upper extremity injury. So it's not predictive for shoulder pain in baseball players in this study. Study of Larsen, 2014. I'm following the years. Maybe you saw that. Reduced glenohumeral rotation, external rotation weakness, scapular dyskinesis are risk factors for shoulder injury. 206 handball players, obvious scapular dyskinesis, predicted shoulder injury. Odds ratios of 8.41. That's massive. 8.41 is very large. But I included here the confidence interval from 1.47 to 48, for an odds ratio of 48. So as you can see, there's an extremely large confidence interval. So what does that mean? That means that this study says scapular dyskinesis predicts shoulder pain, but we don't know how precise, and we don't know whether it's a very large predictor or maybe not that large predictor. But it does predict shoulder pain in handball players. Then the study we performed in overhead athletes, 113 overhead athletes. Our results were very clear. None of our characteristics predicted shoulder pain. And we measured scapular dyskinesis as one of the predictors, and scapular dyskinesis was not predictive for shoulder pain. In a follow-up study, we followed those athletes for 2 years, and we measured them in between, and never was scapular dyskinesis predictive for shoulder pain. And the last one here is from Shitara, 132 baseball pitchers, and their results, scapular dyskinesis is not predictive for shoulder injury. So as you can see, this is something what we would call conflicting evidence. Some say yes, some say no. There is a difference in sports, of course. Some say yes, some say no. I've put them all together in one table to look at the differences between those studies. Is there a gender difference in all those studies? Look here, 100% male, 100% male, 100% male. In our study, we had 50-50, and the other one was 100% male. So I don't think we have clear evidence that gender is, for the moment, a difference. And as you can see, this one, the Kawasaki and the Larsen, were the one that predicted shoulder pain. Is it a type of overhead sports? Rugby, baseball, handball? We had a whole combination of sports. Or again, baseball. And these were the ones who were predictive. Yeah, maybe we can say handball and rugby players are at risk and the other ones are not. However, in our group, we also tested the handball players. We took them out for analysis, and they were not predictive for shoulder pain in our review, in our prospective design. Is it the way they classified scapular dyskinesis? No, they all used visual observation, followed the McClure and Mitchener protocol, obvious or not. They just looked, is it present, yes or not? All the same. Is it the level of sports? And here we have some difference. Look at the ones that predict shoulder pain. And we see a clear difference. Here the rugby players were top league players. The handball players were elite level players. And we had recreational level, high school players. It's not that I'm not a statistician here. I'm not saying that the elite level players there is a predictive value there, but I'm just presenting you that maybe the amount of load is the thing that's important here. If you have scapular dyskinesis, then maybe it's not predictive if your shoulder is not that loaded. But if you have a shoulder that is loaded every day, every hour of the day, or almost every hour of the day, then maybe that's a small factor, scapular dyskinesis, becomes predictive for shoulder pain. So that were the two cases, and I said I wanted to look at the soccer team for it. And I think it's, if you look at a soccer team, an elite soccer team like this, first on the world ranking, they're all factors. You got the keeper, and maybe you can look at the keeper as your scapula. And you got some defenders, which is the cuff, and you got the attackers. And you should look at the scapula, at the shoulder like that. If a team like that loses with 0-5, and they interview the coach afterwards, the coach says, well, we played bad. We have to look at the reason why we had 0-5. The keeper had 5 goals in, and our attackers didn't score. And yeah, we have to look at the whole team and see what's needed, what are the potential little weak links, but we need to look at the whole team. The coach will never say, oh, it was the keeper. He let the 5 goals in. It's the keeper. That's the one to blame. But why do we want to look at the shoulder like that? Oh, it's the scapula. It's the supracromial space. It's the pec minor. It's the posterior capsule. That's the one that's creating the problems. No, the shoulder is a team. Is a team of attackers, of defenders, of a whole team. And I think it's very important to look at the shoulder and probably other joints too, of course, but look at it as a team working together. And if you put in this team, if you put a guy in there that is not able to play soccer, and he's a very weak link in the team. If I would join this team, the chances that this team will lose the game are pretty high. So if you put a weak link in a strong team, then it will be predictive for loss. But if I would join a small team in my village, they probably don't know that I'm not a soccer player. They won't recognize me as a bad player. So maybe that's a nice way to look at the shoulder. But that's, of course, my clinical way of view, not my research way of view. Thank you.
Thank you very much.
First of all, I would like to say thank you for inviting me here today. And the title of my presentation is The Effect on Pain of 8 Weeks Training with and Without EMG Biofeedback, a randomized controlled clinical trial in patients with shoulder impingement, which is a pilot study. And the background for this study is, as you have heard several times during these last days, that supracromial impingement syndrome, comprising both shoulder pain and disability, is one of the most common shoulder disorders registered in primary care. And may be due to a compression and or inflammation of supracromial structures such as rotator cuff muscle tendons and the supracromial bursa underneath the acromion and the coracoacromial ligament, potentially caused by an inappropriate scapular humeral movement and thereby causing a narrowing of the supracromial space. However, as we have just heard, there are a lot of discussion in this area also. Alterations in neuromuscular activity is an aspect of the neuromuscular scapular function, which is thought to be related to CIS. But also here, this picture is not quite clear. It could also be exposure specific. So despite the results from previous exercise studies, there is still a knowledge gap concerning the effect of exercise training, specifically aimed at changing the load sharing of the scapular muscles. And the concept of neuromuscular control highly influenced the choice of treatment for CIS. But the question is if patients with shoulder impingement will be able to train more effectively if they get feedback on muscle activity from the muscles they are supposed to activate. So previously, EMG biofeedback with visual guidance was shown to be effective in selective activation of the scapular muscles. Also in patients with CIS, possibly by means of an improved proprioceptive function of the scapular muscles. And the recommendation from these studies was that further investigation of EMG biofeedback in shoulder treatment is needed. So the aim of this study was to examine if patients with shoulder impingement would benefit more from an 8-week scapular-focused EMG-guided biofeedback program compared to the effect of the same program without EMG biofeedback. And the inclusion criteria for CIS were at least 30 days with pain or discomfort in the shoulder and neck region within the last year. And as I recommended in the literature, a group of tests may be suggested as a diagnostic tool, and we therefore used a clinical reasoning algorithm based on a standardized battery of clinical tests. So in the clinical examination, 2 or more positive impingement tests were to be present. And for the exclusion criteria, more than 8 on a numeric rating scale in relation to pain or discomfort for the last 24 hours on the test day, and more than 3 regions with pain or discomfort for 30 days or more during the last 12 months. And further exclusion criteria are listed here. So moving on to the outcome measures. As primary outcome measures, pain levels were registered at baseline and follow-up using a numeric rating scale. And the patients filled out their actual shoulder pain level within the last 24 hours, and pain level during the last 7 days. But due to differences in questionnaires used in this study, pain within the last 24 hours and the last 7 days are on a scale from 0 to 9. As secondary outcome measures, we included the self-reported outcome measure disability of arm, shoulder, and hand questionnaire, the DAS, including 2 optional scales on sport and work. And also the Oxford Shoulder Score to measure shoulder function. Also measurements of scapular position and function, and electromyography measurements during a functional test of the trapezius and serratus anterior muscles were included. However, these outcome measures are not a part of this presentation today. So, moving on to the methods. Based on previous studies on muscular imbalance between upper trapezius, lower trapezius, and serratus anterior, a standardized intervention program was developed consisting of exercises selected after best evidence for activating the lower part of trapezius and serratus anterior. And the patients were supervised once a week by the same physiotherapist and instructed how to progress and to do the exercises with 2 times 10 repetitions once a day during the 8 weeks of intervention. And the only difference between the 2 groups was that during the weekly supervision, the EMG group received EMG bar feedback on muscle activity in relation to the exercise instructions, and the other group only received the exercise instructions. And the program here was divided in 2 phases, and the purpose of the first 3 weeks was to relearn how to activate the lower trapezius and serratus anterior, thereby increasing the awareness of the position and function of these muscles. And the purpose of the second phase was to transfer the experience gained through the first phase, and here the patients had to activate and use the muscles in more functionally related exercises. And also a few stretching exercises and economic instructions were given too. So these were for both groups. Now moving on to the results. This flow diagram gives or provides you with an overview of the trial design, starting with recruitment at local advertisement and clinical referral. And after the initial contact, eligible participants were invited to a clinical screening, and those who fulfilled all inclusion criteria were invited to participate in the study. So out of 104 participants who volunteered for this study, a convenient sample of 49 patients were randomized to either one of the interventions, and we ended up with 26 patients in the EMG group and 23 patients in the no EMG group. And in total, 5 patients were lost to follow-up, leaving 44 study completers, and the total 49 patients were included in an intention to treat analysis. So what did we find? Regarding baseline characteristics, as expected, due to the design of the study, no significant differences were found between the 2 groups. And looking at the baseline pain and function scores, again, no significant group differences were observed. And regarding our primary outcome measures, with an overall high compliance for both groups, no significant differences in between-group change were found. However, the analysis revealed a within-group change, seen as a decrease in pain levels from baseline to follow-up in the majority of pain scores. And for the secondary outcome measures, again, no significant differences in between group change were observed. However, for both groups, we found a significant difference in within-group change displayed as an increase in shoulder function from baseline to follow-up in the DASH score, the DASH work score, and the Oxford shoulder score. So, to conclude on the results of this study, no significant differences in between-group change were found in relation to pain and shoulder function. However, significant differences in within-group change were found in relation to both pain and functional disability. And future analysis of EMG and scapular assessments will potentially give us indications of the relationship between pain, function, and biomechanics. This study has some limitations, however. There's a lack of a control group without any treatment, which could have provided us with insight into possible placebo effects or spontaneous tissue healing. There's a large heterogeneity of the patients, with a large age span, different social status, working conditions, besides multiple reasons for developing their impingement symptoms. And a relevant question is, would the results have been different if patients' eligibility also was related to positive signs of scapular dyskinesis? And there was a lack of optimal medicine registration and diagnostic imaging. In the end, I would like to acknowledge all the people involved in the study and the funding agencies, and I will also acknowledge the Health Sciences Research Center at the University College Lillebælt for giving me financial support to be here today. So, thank you for your attention.
Thank you very much.